And I have a fair bit of material to cover. Anyone who present who has been at Dalhousie, all you friends who we met before will find some of this material familiar, because I do work with residents and we learn together about sleep. But anybody else, I'm not sure how much experience do you have with sleep. So my intent today is to touch on the very basics of sleep physiology. I will spend a little bit of time talking about the sleep diagnostic tools, and then we will move on to sleep disorders that are common in older adults. And finally, I will talk about insomnia and its management, as I think this is something that most of you will have to deal with at some point in your career. So sleep physiology, we distinguish different types of brain activity, both during wakefulness and during sleep. And the best way to characterize them is by describing the different types of electrical activity in the brain. And you will see, can you see my pointer? Okay, so you will see the different types of electrical activity, which we can see on the image as different speeds. When we talk about the frequencies, that is the number of waves per second, otherwise called hertz. And you will see the faster activities that are associated with more robust state of wakefulness. For example, here in the stop line, we see a mix of alpha and beta waves. When we start seeing the alpha waves, that's a more relaxed state, and but still wakefulness. And then as sleep approaches, we will see a slowing of the waves, so a lower number of waves per second, such as theta waves that you will see over here. And that corresponds to stage 1, as we are just drifting off and transitioning to sleep. The waves become even more slower and the amplitude becomes bigger as the deeper sleep we enter. And then finally, we enter the deepest slow wave sleep, and it's called that way because the waves are really slow. You will see those big amplitude, very wide waves that correspond with the deeper stages. Those different sleep stages will progress across the night. And here is an example of a progression of sleep stages where we go from wakefulness through the transitional stage 1 and then on to the stage 2. And finally to the deeper stages of sleep, only to come back to rapid eye movement sleep, or REM sleep, as I will call it from now on. And that cycle from onset of sleep until REM period, REM sleep lasts approximately 90 minutes in a healthy individual. And you will see that it continues throughout the night. So we have a number of cycles, REM, non-REM sleep cycles that are repeated throughout the night. And mostly it reflects the progression of REM sleep, majority of which we see in the later part of the sleep period, and majority of the slow wave sleep we see in the earlier part of the night. What I would also like to emphasize here that there are disruptions in the sleep cycles, and there are we see on this graph that the subject becomes awake during the night, and in fact it is perfectly normal for an adult to wake up multiple times during the night. It's estimated that a healthy adult has on average 10 to 15 arousals per night. Most of the time we go back to sleep and we don't realize that those arousals have occurred, but they are there. And those arousals increase with age, with anywhere from 20 to 30 arousals per hour being considered normal in a healthy older adult. So what controls sleep? There are two basic mechanisms that control sleep. One is the homeostatic mechanism, which basically means that the pressure to sleep builds up and increases along with the duration of wakefulness. So the longer time from our last sleep, the more likely we are to fall asleep. How much sleep do we need, and what is the appropriate duration of sleep and wakefulness? Well, that varies from individual to individual. For most adults, we estimate about between 7 and 9 hours is appropriate or necessary amount of sleep, but this can vary. And as you will see, this is pretty much a bell curve, with some individuals requiring as little as 5 or 6 hours of sleep, and some individuals requiring 10 or more hours of sleep, and that is still within the range of normal. The second mechanism that we talk about in control of sleep is the biological clock or the circadian rhythm, which is controlled by suprachiasmatic nucleus. And we see a progression of sleep pressure depending on the time of the day and the point of the individual's sleep circadian rhythm. Ideally, we want to see those two rhythms coincide, that the strongest pressure for sleep occurs at the right time of the night, so in early in the evening, and we ideally it coincides with the homeostatic process that we've been awake at that point for sufficient amount of time to generate sleep. Now, this graph will show you the differences in sleep between a young adult and an older adult. This is a schematic representation, but I really want to emphasize that sleep is a very dynamic process that undergoes maturation and changes throughout lifespan. So those of you who know young children or have children, you will probably remember how much an infant will sleep and what will be the difference in the sleep between a toddler and a school-age child. And we all get annoyed when we have young kids who tend to wake up at 6 o'clock in the morning while we want to rest. But this is perfectly normal. And then the circadian rhythm and sleep process undergoes changes. The same lovable, wonderful children who were waking up at 6 o'clock when they were little become adolescents, and then it's very hard to wake them up before noon. And that's, again, perfectly normal. This is a physiological thing. And this process continues into older age, where when we grow older, again, our circadian rhythm shifts and we start waking up earlier in the morning and we want to go to bed earlier in the morning. So that's one difference in sleep between during age. The other thing you will see what I already mentioned before, that there is much more wakefulness during sleep. The latency to sleep may not be that different, but there is much more fragmentation in sleep. We see much less slow wave sleep in older adults and slightly less REM sleep. Here is another way of looking at it. So from from a newborn until old age, you will see how we spend more time awake, the amount of REM sleep decreases and the amount of slow wave sleep decreases. So we really have to expect changes. And it's key in understanding sleep complaints in our patients who are older. So once again, overall amount of sleep tends to decrease. With age, we spend more time awake during the night. There are more arousals, there is less deep sleep, and there is the advance of the circadian clock. So in the clinical care of patients with various sleep disorders, what do we do? How do we diagnose? I did not write it down on the slide, but obviously the first and the most important part is taking a very careful history that includes detailed questions about sleep patterns and sleep routines and various behaviors related to sleep. But once we have that information, a gold standard test when appropriate for some disorders is polysomnography. Then we also do what we call level 3 studies, or also called home sleep apnea testing, and I will explain shortly what that means. Sleep diaries are my very favorite tool in diagnosis, very easy and inexpensive to use. And finally, there is also a technology called actigraphy. So let's start with polysomnography. That's a test that involves collecting an awful lot of information. And here in the picture, you see what the patient looks like once they are in the laboratory and attached to all the equipments. You will see the number of wires and sensors that are everywhere. But essentially, a standard sleep study or polysomnography involves 4 channels of electroencephalography, 2 channels of eye movement tracing, 3 channels of electromyography. We collect information about muscle tone from the chin and from both legs. We measure airflow at the nose and mouth, as well as respiratory effort, because we want to know whether there is any, whether the breathing is of central or obstructive origin. Oximetry is monitored continuously. In some patients where it's appropriate, we also measure transcutaneous CO2. There is a microphone in the laboratory, and the patient remains under continuous observation through an infrared camera. So having attached all those sensors to the patient, we put them to bed and tell them good night, and then we proceed to watch them. Normally people ask me, and you expect me to sleep with all those wires on? And they swear that they will never fall asleep, and then they fall asleep within very short time. So that's a polysomnography, and this is an image that shows you what the recording looks like on the screen when I look at it. I won't go into the details, but you will see that it provides very rich information about a lot of physiological parameters. So level 3 study, also called portable apnea monitoring or home sleep test, are becoming more and more common and available. In Canada, they are widely available through private home care companies that provide CPAP devices to patients. So they will also do those tests. And most of the time, those are very helpful tests, which are easily accessible. They are inexpensive. They are very convenient because the patient is at home while the test is, so they sleep in their own bed. There are fewer sensors, and this is what's important to remember, that those tests do not record sleep because they do not have EEG or all the other signals that allow us to determine sleep or sleep stages. They measure respiratory variables such as respiratory effort, airflow, oxygen saturation. Many of those devices will also tell us what is the body position, and they have a microphone built in to tell us whether the patient is snoring or not. The major disadvantage of that is that it's unattended. So if a sensor falls off or malfunctions, then there is not much we can do about it. But it's widely used, and in many patients, it's a very helpful diagnostic technology. An actigraph is another type of sleep diagnostic technology. It's you will see what it looks like. It's like a big smartwatch, and it simply measures movement. Some of the devices also have a light sensor built in that allows us to determine what is the amount of ambient light in the patient's environment. But basically, it tells us whether the person is moving or not moving. And then that helps us to understand, or we infer from that whether they are asleep or not. But it's an indirect measure of sleep and wakefulness. And finally, the sleep logs. So I love using them. I use them with most of my patients. And in fact, most of my patients are asked to complete sleep logs before they come for their first appointment. This is what a sleep log looks like, and you can access them quite easily through probably the easiest would be mysleepwell.ca website, and there is a lot of different formats, but it basically tells you information, what time the person went to bed, how long it took them to fall asleep, whether they were awake during the night and for how long, then what time they woke up and what time they got out of bed, because those two numbers aren't always the same. And finally, we also ask, did you nap? Did you take any medications? And how did you perceive your sleep? So those are the tests that we are, the main tests that we are using in diagnostics of sleep disorders. And unless you have any questions, I'm going to move on now to specific sleep disorders.
Any questions?
Okay, let's
All right.
move on. We have a lot of ground to cover. So I'm going to talk now about sleep apnea. Although many people will consider this mostly a respiratory sleep disorder, but I will argue that this is a very highly relevant to psychiatrists. What is sleep apnea? So we distinguish obstructive sleep apnea and central sleep apnea. The central obstructive sleep apnea is much more common. It is a closure, either full or partial, of upper airway, which leads to decreased or absent airflow. And in consequence, it causes a drop in oxygen saturation and arousal, because the patient has to wake up, the sleep is interrupted, so that the muscle tone can be can return, and the airway will open. We distinguish different types of respiratory events. So when we talk about an apnea, that means that there is a complete cessation of breathing, and we start counting when it's more than 10 seconds. So if anyone here wants to hold your breath and count to 10, you will know how long we will see it on the recording technology. Apneas can be obstructive, where there is closure of the airway and we see continued or even increased effort to breathe. Or we can see central apneas, where the respiration ceases and there is no respiratory effort. So those are centrally driven events, and we see them mostly in individuals with heart conditions such as atrial fibrillation or heart failure. They can also occur in the presence of CNS lesions or in kidney failure. And also not to forget that central apneas are quite a common phenomenon in patients with chronic pain who are using opioid medications. Now, hypopnea is a reduction of the breathing, reduction of the airflow of at least 50%. And again, we start counting when it's more than 10 seconds. And the hypopnea either leads to an arousal or to the saturation from baseline of at least 3 percentage points. We also distinguish respiratory effort-related arousal. So we see 10 seconds of heightened respiratory effort and some changes of the nasal pressure waveform. But that is a very purely polysomnographic phenomenon. So we won't get into that. How do we define the severity? So we can see the apneas and hypopneas, we add them all up and count them and divide it by the time asleep. Anything less than 5 per hour is considered normal in an adult, and anything between 5 events per hour and 19, depending on that also depends on the definition, but either 19 or 15 is considered mild. Moderate, anywhere from some sources consider 15 to 30, others from 20 to 40 events per hour. And anything more than 30 or 40 events is considered severe sleep apnea. But remember that those are very arbitrary categories. And we also have to think about other factors such as degree of the saturation, presence or absence of daytime symptoms. The reason why I think it's highly relevant to psychiatrists is that untreated sleep apnea can have quite significant neurocognitive consequences. We see depressive symptoms with an odds ratio of more than 2.5 in patients with sleep apnea developing depressive symptoms. And there is a fair bit of overlap in the diagnostic criteria between symptoms of apnea and symptoms of depression. So it's worth considering. And cognitive impairment, which is felt to be mostly linked with the degree of and frequency of oxygen desaturations. The cardiovascular consequences can also be quite significant with predominantly hypertension and other cardiovascular diseases being linked to untreated sleep apnea. And it can go all the way to cor pulmonale. There are also there's also possibility of arrhythmias, and definitely untreated sleep apnea does carry an increased mortality risk. So how common is that? If we define sleep apnea as more than 5 events per hour plus daytime sleepiness, it's about 4% of middle-aged women and more than 6% of middle-aged men meet the diagnostic criteria. If we only count the apnea-hypopnea index, more than 5, without other symptoms, particularly without daytime sleepiness, the prevalence goes way, way higher, with about 22% of middle-aged men meeting that threshold. So it is common. In the diagnosis of obstructive sleep apnea, polysomnography is considered the gold standard. But in patients who do not have significant comorbidity, who are otherwise fairly healthy and have high pre-test probability, a home sleep study is perfectly appropriate and can serve to confirm the diagnosis. There are also questionnaires that I would encourage you to look at, such as Stop Bang questionnaire, or another is Berlin questionnaire. Those are highly sensitive questionnaires that can be easily used in the office to identify patients who are at risk for sleep disordered breathing. With respect to treatment, some patients who, especially those who carry extra weight, we believe that their apnea would probably improve if they were able to lose weight. But in my rather long career, I have not seen too many people who were able to accomplish that, unfortunately. Some individuals will have respiratory events predominantly when they sleep on their back. And there are devices that patients can purchase or make for themselves to train themselves to sleep on their side, and that can eliminate the sleep apnea. The gold standard in treatment is positive pressure devices such as CPAP, which stands for continuous positive airway pressure. And there are variations of the positive pressure therapy such as auto CPAP, where a little bit more sophisticated device will adjust the pressure throughout the night. And there are other forms such as bi-level devices and auto servo ventilation, which are more reserved for specific cases. Another type of treatment is an oral appliance, also called mandibular advancement device. You will see here on the image how it works. It has to be fitted by a trained dentist. And it can be quite effective. It's recommended for patients who are of normal body mass and with mild to moderate sleep apnea. The device will pull the mandibula forward and hold it in the position while the patient is asleep. So it will shift the base of the tongue in the anterior wall of the airway to open up the airway here. That tends to be expensive and is less likely to be covered by private insurance plans, where we can more easily get. Now, CPAP is pretty much covered by all the standard insurance plans. The last resort would be surgery, which can be done on the facial bones to mimic the in a more permanent fashion the advancement of the mandibula to increase the size of the airway. The next disorder I want to discuss is something that you are going to see in your practice quite guaranteed, which is the REM sleep behavior disorder. We have a DSM definition and a diagnostic criteria, but essentially what it is, it's a loss of the muscle atonia in REM sleep. So the muscles remain active, and the patient is enacting their dream content. This is one type of parasomnia disorder where a sleep study is indicated and necessary to confirm the diagnosis. On a sleep study, we will see increased density of rapid eye movements during REM sleep and bursts of EMG activity on both chin and legs during REM sleep. So there is a definitely abnormal muscle tone during REM sleep. It's estimated that it affects 1 to 2% of people in general population, and it's more common in men. It tends to occur in older adults and it is very strongly linked to synucleinopathies, with estimated several years emergence of RBD symptoms prior to the neurodegenerative disorder manifesting. It can also have an autoimmune source, or it can occur with brainstem lesions. But also important to remember that it can be caused by all the good medications that we give to our patients. The major risk of that is injuries to either the patient or their bed partner. The episodes tend to be quite short, seconds to minutes. It doesn't have to occur every night. Even if we don't have a description of the acting out of dreams, or the acting out of dreams occurs once in a while, but still the elevated muscle tone during REM sleep is pretty much present every night, because that's the basic pathology here. In management, we have to think about neurological evaluations, look for development of Parkinson's, so any movement disorders, in patients with Lewy body dementia, so careful neurocognitive evaluation. It's very important to address safety. I have seen in my practice bed partners with broken noses and other injuries. So safety not only for the patient, but also for whoever happens to sleep in the same bed next to them. And the management so far remains medications. The first line recommendation is for clonazepam in a small dose at bedtime. Of course, it can be problematic in some elderly patients, especially with cognitive decline. Alternative is melatonin in fairly high doses, 3 to 12 milligrams a night, and sometimes we go higher than that. There is some mention in the literature of dopamine agonists or acetylcholinesterase inhibitors, but there are also mentions in the literature about those agents possibly triggering RBD. So the jury is still out on those items. And here is a short list, not complete, of medications that can trigger RBD episodes. So we used to think that this is a purely iatrogenic. Now there are some authors suggesting that the patients who develop RBD in response to those medications are probably those who would have developed RBD anyway later on in life, and that the medications only uncover that. Important to remember is that during withdrawal from REM suppressing medications or from alcohol, which is a potent REM suppressant, you may see episodes of RBD. So the next disorder I want to mention is restless leg syndrome. Kathy, I see that there are some things showing up in the chat. Are you monitoring if there is anything urgent?
Yes, I'm monitoring. So there's 3 questions, and I wasn't sure if you wanted to save those for the end or dive right into them.
Well, this may be a good moment to interrupt before we move on.
Okay, sure. So Dr. Canfield has 2 questions. Has anyone in Ontario been able to see a patient have a level 3 study, or how can we access them for patients? And how reliable is actigraph data, and how do you use it clinically, Dr. Rajda? So 2 questions there.
Okay, so I'll start with the actigraph. Actigraph data is quite reliable, but remember that it does not measure sleep directly. It measures activity and inactivity. So the actigraph is most useful in longitudinal assessment of patterns, because the device can record, depending on the manufacturer and lifespan of the battery, it can record 1 to 2 weeks of data at a time. So it's most commonly used in diagnostics of circadian rhythm disorders, and it can be used for monitoring response to treatment of things like insomnia. And as far as the level 3 studies, I'm not sure what the extent of access is in Ontario, but in Ontario, you have much easier access to sleep laboratories than in other parts of Canada. So many of the sleep laboratories will perform level 3 studies, the home sleep apnea tests, at the discretion of the sleep physician who has assessed the patient. Or you can refer a patient to a home care company that sells CPAPs. This is what we do in the rest of the country. And they will perform a test like that. And but what is important with the level 3 studies is that you make sure that the report you're getting is interpreted by a trained sleep physician.
Okay, so I guess what you're saying is that it not always is. Gotcha.
Yes.
Okay.
Yes.
All right.
Yeah.
Thank you. And one more question for the mandibular surgery procedure. Is there a requirement to first complete oral mandibular advancement with oral device so as to define benefit? No?
No, most surgeons do not do that. Our surgical colleagues have very sophisticated means of analyzing the bone structure and modeling the amount of movement that they can perform in the surgery. So they do not require, and also the surgery alone is capable of providing much more more significant movement and more advancement of the mandible than than the oral device.
Okay, so that's it for the questions at this point.
Okay, so let's move on. What time is it? We have 20 minutes left. So restless leg syndrome. This is a very common condition, and it's a major differential with insomnia. Patients will complain about this extremely unpleasant sensation, usually in their legs, that's associated with a strong urge to move. It occurs during inactivity and is partially or completely relieved with movement. Now, the relief is not long-lasting, and the sensation improves while the patient is moving, and when they stop moving, it comes back again. There is a circadian pattern to the symptom. It happens predominantly in the evening when the patient is resting in bed and trying to fall asleep. It is not the same as periodic leg movements, which is a polysomnographic phenomenon where we see rhythmic twitches, rhythmic contractions of the legs. Restless legs is a clinical diagnosis made by history alone. And here is a really good screening question that has been shown to have a sensitivity of almost 100% and pretty high specificity. When you relax in the evening or sleep at night, do you ever have unpleasant, restless feeling in your legs that can be relieved by walking or movement? So if the patient says yes, then it's pretty much guaranteed that that they have restless legs. As I mentioned, the clinical history is the mainstay of diagnosis. We do physical examination to rule out some primary causes. Same with laboratory tests, but we do not need to do any sleep tests. So a patient with restless legs does not need to be referred for a polysomnography or other sleep study. It affects estimated 5 to 10% of general population. It becomes more common as we grow older, and it's very commonly associated with iron deficiency or kidney failure. It's something that is very commonly seen in dialysis units. Important for psychiatrists, it can be drug-induced, and here is a partial list of medications that are linked to restless legs. As you see, it's a lot of things that we use in our daily practice with patients. If the restless legs occur intermittently, if it's not every night, my first line is review the medications and see what can be stopped or decreased. My first line would be the Cinemet or carbidopa, levodopa combination in a small dose. If that doesn't work, I would move on to dopaminergic agents, or low potency opioids have also been quite helpful. But again, in elderly population, we want to be careful about that. Patients who have daily restless legs, the first line treatment will be dopaminergics, oral, such as pramipexole or ropinirole, or a patch like rotigotine. And then there are other options that I would consider in patients who have not responded to dopaminergic therapy or have unacceptable side effects from dopaminergics. Augmentation is a phenomenon that occurs with long-term treatment with dopaminergics, especially with L-dopa or carbidopa. And that is where we start seeing leg restlessness earlier in the day, or there is an increase in severity, or the symptoms spread to upper limbs. We don't really know that well what to do with it, but the important thing will be to withdraw from the dopaminergics when we see augmentation and switch to something else. So before I move on to insomnia disorder, let's see what's, okay, for some reason, oh, here it is. I see. Regarding clonazepam and benzos, I have used it for RBD, but the notice reads that it may cause hazardous sleep-related activities. How do we make sense of this? These behaviors must be in REM. Well, in patients with REM behavior disorder, we have to obviously balance the risks and benefits. At present, clonazepam is recommended first-line treatment, but we do have to monitor daytime sedation. And REM behavior disorder, as the name indicates, it occurs during REM sleep. Can you tell us the dosing, titration, and max that you typically use for pramipexole? Yes, in adults, I start really low at 0.125 milligrams and titrate the dose against the symptom control or side effects. So start low and go slow. Okay, I'm not going to read to you the diagnostic criteria for insomnia disorder, but because you can look at, you can see it here. But generally, we are talking about difficulty in either falling asleep or staying asleep or waking up too early. And that's linked with racing thoughts, ruminations, and a lot of anxiety. In order to meet the diagnostic criteria for an insomnia disorder, we also need to see a daytime impairment. So that could be a sense of fatigue and feeling unwell. But I want to emphasize that daytime sleepiness is very rare in patients with insomnia. And in fact, when you ask them if they take naps, they usually say, I just can't fall asleep during daytime, or I struggle with sleep at night, so I don't take naps. And ask them if we do tests such as a poor sleepiness scale or measure their sleepiness in any way. Those are not sleepy people. If you have a patient with insomnia at night and daytime sleepiness, I would evaluate them for another sleep disorder. But mood disturbances, grumpiness, crankiness is quite common. They are often preoccupied with their sleep and worry about their sleep. And many of those patients have comorbid anxiety and have lots of symptoms of anxiety, including the somatic symptoms. So even though the patients may complain about subjective cognitive impairment, there isn't really a correlation with objective evidence in executive function, psychomotor function, or other modalities. So people don't feel well, but there is no objective evidence of impaired function. It is very common, with an estimated 10% of general population suffering from insomnia, and anywhere from at least 30% of general population will have some sort of sleep issues at any point in their life. We evaluate those patients by taking history. We can do sleep questionnaires specific to insomnia measurement. And as I mentioned before, my favorite sleep diaries are very helpful in evaluating their sleep habits. Polysomnography is not indicated in evaluation of insomnia unless you think that there is a comorbid another sleep disorder. So here is a list of some of the questionnaires that we use in evaluating the severity of insomnia or monitoring their progress during treatment. As I mentioned, polysomnography is not indicated. And now what do we do? So first, I conceptualize insomnia. Well, as Spielman taught us many decades ago, along the biopsychosocial formulation of the predisposing, precipitating, and perpetuating factors. So women tend to be more likely to develop insomnia. People who are single, divorced, widowed have higher chance of developing insomnia. Lower education, lower socioeconomic status, use of alcohol, early life experiences or adverse experiences in early life, all of that will predispose people. The precipitant can be something quite innocuous, like changes in the environment, a new medication or illness, something that interferes with sleep. But the most important are the perpetuating factors that will maintain the insomnia complaints. And those factors occur in either behavioral and or cognitive domains, and more commonly both. So people try to compensate for the poor sleep at night. They start spending more time in bed. They start taking or trying to nap or rest during daytime. They use various substances. They worry about their sleep. All of that leads to a worsening of their sleep problem. CBTI, or cognitive behavioral therapy, is the first line recommended treatment, and it is recommended by many professional bodies from all over the world because it works. It has very significant effect in majority of individuals who will engage in the treatment. The effect lasts. Here you have a couple of graphs showing comparison of CBTI against temazepam. So in patients who were treated with temazepam for their insomnia at 24-month follow-up, they were pretty much back to baseline with their insomnia complaint, while individuals who underwent CBTI at 24 months not only maintained their gains, but continued to improve. That's with respect to both total sleep time as well as latency to sleep. Need I say more? So CBT combines both cognitive and behavioral strategies. Typically, it's a therapy that is fairly short-lived, averaging 6 sessions, and it can be delivered in person or in a group. It can be delivered online. There are many resources for self-delivery, self-administered CBTI. So we really have many options here. The therapy consists of several techniques listed here from top to bottom, how effective they are. So sleep restriction and stimulus control are the most important and account for most of the gains. Relaxation training, cognitive therapy are also important parts of therapy, and I will have something to say about the sleep hygiene. So what is sleep restriction? We review the sleep diary with the patient, which may give us this sort of information that the patient goes to bed, then they are awake for a while, then they sleep for a bit, and we have some periods of wakefulness during the night. Based on this information, we calculate how much the patient actually slept during the time and give them prescription for time in bed. So in this particular instance, we will eliminate the early bedtime of 11 and advise the patient to go to bed at 2 o'clock, which is 3 hours after their habitual bedtime, and continue and maintain the waking time at 7 a.m. So although they are spending more time in bed, they are not actually sleeping less. They are still sleeping the same amount as they did before. Their sleep is better consolidated. And once they achieve that consolidation, we can gradually increase their time in bed. Stimulus control is based in the concept of breaking the learned association between the bedroom environment and wakefulness. So we tell people to get out of bed when they are not sleeping and go to bed only when they are feeling sleepy. But they still have to get up at the same time every morning. So there is no mercy here. And those two measures account for 80% of the CBTI effect on sleep. Relaxation training or mindfulness is a very useful adjunct to therapy that allows the patient to reduce autonomic arousal. And finally, cognitive therapy, with which you are all familiar. It addresses the maladaptive or dysfunctional thoughts that lead to elevated arousal and continue to affect their ability to fall asleep. So now sleep hygiene as standalone is a set of general guidelines of not eating well, not drinking alcohol, avoiding caffeine, not napping, exercising, and all those good things in life. But it really is a minor component of the treatment because it is not very effective when used on its own. And 2021 guidelines from American Academy of Sleep Medicine actually recommend that clinicians do not use sleep hygiene as a single component therapy. So I have here a few resources, but what I think that maybe I will just send those slides with those resources to Dr. Hickey, and you can use them because there are resources for online for patients, there are books, and there are resources for therapists, and where you can train in this. So when it comes to medications, this is a very busy slide. This is a guideline for pharmacologic treatment of chronic insomnia in adults, which was published by American Academy of Sleep Medicine. But what I really want to draw your attention to is that with respect to all the medications that are listed here, and those are really all the things that people are using in treatment of insomnia, the evidence is weak for every single of them. So none of the currently used medications have any degree of reasonable evidence. In Canada, we have Z drugs, we have benzodiazepines, we also use sedating antidepressants, and more recently we have the DORAs, so dual orexin receptor antagonists. Kathy, how are we doing for time?
We are at 2:30. I'm just wondering, do you have an extra 5 minutes if we go over?
Yeah, I do.
Okay, thank you.
So let's talk about the medications that are available in Canada, because the story is a bit different in the US. So the most common ones in Canada are the so-called Z drugs and benzodiazepines. Z drugs are simply selective, more selective with respect to the GABA A receptor, and when given in high enough doses, they become regular benzodiazepines. So the main difference is that they attach themselves to the alpha-1 subunit, and by that reason they have predominantly hypnotic effect, but they can also affect memory. And you will see here the differences, like zopiclone will have a high affinity, S-zopiclone also has a high affinity to the alpha-1 subunit. The same goes for zolpidem and zaleplon. This is a little bit of information about their pharmacokinetics. They differ in their half-life. In the Beers criteria, all recommend that those medications should be avoided in the elderly. So in the older population, we use lower doses and try to avoid it if possible. Generally, we see sleep induction within 30 minutes when using benzodiazepines, but because of their receptor profile, we see much higher risk of falls, accidents, and daytime sedation, as well as memory problems. So again, the Beers criteria recommend to avoid those agents in older folks. With respect to antidepressants, so far there is very limited data on efficacy in general and even less on use in elderly. Those traditionally used would be trazodone, mirtazapine is commonly used, and more recently we have doxepin in low doses, 3 to 6 milligrams, and that is based on the antihistamine action. At higher doses, we see more of anticholinergic effect in doxepin, but also with the other medications. But again, the data is limited, and the evidence is weak for all those agents. So they are mostly helpful for reducing the awakenings during the night. Maybe they will not completely prevent the awakenings, but patients tend to go to sleep faster. And they are not supposed to have a cognitive effect or cause motor impairment, but I do worry about the potential for anticholinergic effect in all those medications. They are very appropriate as an adjunct in patients with major depression, especially to counteract the effect of other antidepressants, which may be more alerting and energizing. And now the newest kid on the block, the dual orexin receptor antagonists. The first one on the market was suvorexant, which was approved for use in the United States in 2014. It never became available in Canada. Lemborexant is another orexin antagonist, which was approved for use in the United States in 2019, then in Canada, and then in Japan, and finally just over a year ago in Canada. Those medications have a very different mechanism of action because they affect the orexin receptors. Which means that the concept here is that they reduce the wakefulness, that if you can separate the wakefulness from sleep or sleepiness, by orexin receptors or orexin will suppress REM sleep and non-REM sleep, and it promotes wakefulness through that mechanism. And by blocking the orexin receptors, we see reduced wakefulness, hopefully leading to sleep. I'm going to show you some data from Eisai Medical, which is the manufacturer of lemborexant. So please keep in mind that obviously this is biased data from their pre-marketing clinical trials, but they followed patients over time, and they have shown improvement in both total sleep time and sleep latency, which was maintained over a period of 6 months. but those were some of those were patients, adult patients, and some were 55 and older. And the clinical trial data also showed that the improvement, the gains in sleep were sustained over 12 months. Of course, time will tell us how well it bears out in real life. The other data from lemborexant in comparison to zolpidem was the body sway in the middle of the night and upon awakening. So you will see it compared quite favorably to zolpidem. Hopefully that means that we won't see that as many falls. And to wrap up, insomnia is common. I would really encourage you to consider psychological treatment, particularly cognitive behavioral therapy for insomnia, before you reach for your prescription pad. And I think the jury is still out on the various medications, including the newest ones. There are individuals who will benefit from them when the medications are used carefully and with a great deal of follow-up and attention to the patient's function. But something that I would really like to emphasize, that if you do decide to use the medication, if the patient is not responding, if their sleep is not improving, do not continue the therapy, or if the medication effect wears off, stop the medication. So I'm going to stop now, and let's see what people are asking for.
So there's one last question. You may have put it in the resources, but are you aware of any manuals that have been designed specifically for older adults with recommendations regarding adaptations to consider for seniors?
So there is a text about insomnia in older adults by Charles Morin, and that's it's not exactly a new book. I think it was published sometime in the early 2000s. I can send you the title.
Sure thing, that'd be great. So thank you so much. Whenever a session goes over, that means you have to come back next year for 2 sessions. But I'll talk to you about that. Thank you so much on behalf of everybody. So we'll get the recording up on the GPOP website, and we will take it from there. And thanks so much. I really appreciate it, Margaret. Thanks for your time.
Well, thanks for having me. Good luck, everyone.
Okay, bye now.
Bye.